My name is Chetan Patel. I'm one of the cardiologists here, heart failure cardiologists at Duke, and I've been asked to give a brief summary and update on management of LVAD patients that you as internal medicine residents will be helping us take care of in the hospital. I think it's important to begin by describing how LVAD therapy has really grown over the past decade. Shown here are the total number of implants for long-term durable LVADs, the kind of patients that you'll be seeing on the step-down floors at Duke Hospital over the past 5 years. And beginning in 2010, you can see on the left that the number of implants started to increase dramatically with approval by the FDA of the HeartMate 2, which is one of the pumps that we implant a lot of at Duke Hospital. Over the past 3 to 4 years, there's been a steady growth of devices that have been implanted. And in 2013, 2014, there were over 2,500 long-term LVADs implanted in the U.S. And it's the first time that there were more LVADs implanted than heart transplants done in the United States. And the vast majority of these were implanted in patients who were ineligible for heart transplantation. So patients who did not meet criteria for heart transplantation and will be on LVAD therapy as a long-term care strategy. On the right of your screen is the implant volume for Duke Hospital, and you can see that at least in the last 3 to 4 years, there's been a dramatic increase in the number of LVADs that have been implanted. In 2015, we implanted over 130 long-term durable LVADs, and that made us one of the largest implanting centers in the world. It is anticipated that LVAD therapy will continue to grow. Here we're showing the number of heart transplants done at Duke Hospital over the past decade. It's clear that there's been a plateau, and there will continue to be a plateau in the U.S. There are only 2,200 heart transplants done every year. At Duke, we range between 60 and 70. That's including both pediatric and adult heart transplants. Major limitations are around donor availability and fairly restrictive selection criteria for both the recipient and the donor. What is interesting, however, is that 40% of the transplant procedures done in the U.S. in 2015 were done with prior mechanical support or prior LVAD therapy as a bridge to transplantation. So a lot of the success with LVAD therapy has been due to some technological advances. Shown on your left are the two major mechanisms that are used in the current pump designs. At the top, there is a axial flow design where the blood is spun through the pump and into the aorta from the left ventricle using a helical impeller. At the bottom is a centrifugal flow device, and that is a slightly different mechanism where the blood is spun by a circular rotor, and the blood travels at 90 degrees to the inflow. Both of these designs have a continuous flow technology. What I mean by that is the pump does not try to recapitulate the pumping function of the heart, and does not require a blood sac or a chamber where blood sits and then pumps in sync like a regular heartbeat. These pumps can be smaller because there's a continuous volume of blood that spins through the pump and to the aorta, providing adequate cardiac output. On the right, I am showing the advances in survival with subsequent generation devices, but also with improved patient selection and our better understanding of these devices. So compared to optical medical management, which is the OMM line on the right chart, where you have a 25% survival at 1 year in patients who are supported, for example, with chronic inotropic support. With the HeartMate 2, or the first continuous flow device, we saw a 1 year survival of almost 70%. Subsequent studies, both before and after approval of the device, have shown a gradual increase in 1 year survival, and also in longer term survival at 2 to 3 years. it is now starting to reach, but not quite there yet, the 1 and 2 year survival of heart transplantation, which is shown on that at the top with the top line on the curve. So despite these advances, we are still learning a lot about these pumps. And this is a table from a recent study comparing the axial flow device to the centrifugal flow device. And the idea is not necessarily to show the difference between the two device platforms, but mainly to show that there is a certain number of adverse events that are associated with these devices. Primary of which are gastrointestinal bleeding, stroke, right heart failure, and then pump exchange, typically for thrombotic events within the pump, such that the pump has a thrombus form within the pumping mechanism and it has to be exchanged. So these rates are not low, and these are some of the common things that you will see as a resident on the advanced heart failure service, and that you may be asked to help us manage. So before I actually get into the details of managing each one of those complications, it's important to remember that despite our increasing experience with these devices, there continues to be a high rate of readmission for these complications. And so in a recent analysis done by one of our former fellows, we showed that amongst Medicare beneficiaries who are treated with continuous flow devices, remember these are the devices that show improved outcomes, there's an increase in overall survival over time, which shows an inverse relationship with center volume. But there's no change in readmissions despite center volume. So there's much to learn and much to improve when it comes to managing some of these complications. And primary amongst those are readmissions related to gastrointestinal bleeding, infection, and stroke. And these are two recent publications examining the rate of readmissions with ventricular assist devices. I now tell my patients that over the first year after implant of a left ventricular assist device, the average readmission rate is 1.5. So they can expect 1 to 2 admissions over the first year after implant. And that goes in part to the decision-making process for patients who we are now implanting with left ventricular assist devices. First, I'd like to spend a little bit of time talking about gastrointestinal bleeding. The rates of gastrointestinal bleeding range from anywhere between 10% to 30% of all implants. I quote the patients that at some point during their life they stand a 25 to 30% chance of having gastrointestinal bleeding related to their device. The mechanism has been partly defined. A lot of the bleeding is due to the continuous flow mechanism. Remember that continuous flow really has improved the outcomes after LVAD implantation, but it has some caveats to its mechanism. Because there is a decreased pulse, there is a tendency for patients to develop arteriovenous malformations on mucosal surfaces. Primarily those occur within the gastrointestinal tract and in the nasal mucosa, so there is a higher incidence of gastrointestinal bleeding and epistaxis. The mechanism behind that is thought to be due to decreased pulse pressure and within the GI tract, which leads to AVM formation. But in addition to that, there is the development of acquired von Willebrand factor, where high molecular weight von Willebrand factor is sheared through the pumping mechanism and makes the patient prone to bleeding. When you combine the angiodysplasia with the decrease in von Willebrand factor, there is a setup for gastrointestinal bleeding. This is not dissimilar to critical aortic stenosis, where there is shearing of the von Willebrand factor through the stenosis aortic valve, as well as a low pulse pressure, which leads to AVM formation. In critical aortic stenosis, that is known as Hayes syndrome or Height syndrome. So you will see patients who are admitted for gastrointestinal bleeding. We are starting to believe that there is a high likelihood that the AVMs that are formed are within the small bowel. So initial management strategies for these patients include holding their anticoagulation, but not necessarily reversing them unless they have a a severe bleeding event that is leading to hemodynamic instability. If there is a need to consider reversal, that is worth a phone call to the advanced heart failure fellow or the attending before reversal agents are given. These are typically in the form of vitamin K or 4-factor PCCs, or prothrombin complexes, which is the preferred agent here in our program. After holding anticoagulation, I think it's important to consider resuscitation, and that may be in the form of packed red blood cells. One must note the transplant candidacy of the patient, because exposure to blood products while awaiting heart transplantation can lead to increased allosensitization and development of anti-human HLA antibodies, which may lead to a decreased candidacy for transplantation. For rapid bleeding, there may be consideration of a tagged RBC scan or interventional radiology procedure, but then management is along the lines of most gastrointestinal bleeds based on upper or lower source, and there is an endoscopic evaluation is for the most part indicated in many patients. We have found that a lot of patients who have a bleeding source can be identified with small bowel endoscopy and maybe even more invasive small bowel investigation. And there are areas that are bleeding that can be treated endoscopically, stopping the bleeding. Importantly, after the bleeding event, you have to think a little bit about how you're going to re-anticoagulate the patient. I'm not going to go through this in great detail, but the point being that there may be some modification in the patient's INR goal after a bleeding event, and also in their antiplatelet therapy. This may change depending on the number of times the patient's had a bleeding event, and what we are trying to do here is balance the risk of subsequent bleeding events, which, although associated with a high rate of readmissions and some morbidity, is not associated with mortality. The balance is of course against thrombotic events, which are associated with an increased risk of dying or stroke. The next major problem that you may see after LVAD implantation and may be related to is actually related to heart failure. So, in many ways different from heart transplantation, there is a potential for patients who are treated with LVAD therapy to have residual heart failure. But the management of this is a little bit different to heart failure as we know it. One of the important things is that in a functioning pump, the left ventricular circulation or the left ventricular function might actually be quite preserved, and you may be seeing a significant amount of right heart failure, which has a different management practice to what you usually think of as in managing biventricular heart failure without an LVAD. Here in this example of it, still from an echo, you see that the right ventricle is dilated. You see an ICD lead here, showing you that this is the right ventricle. This is much more dilated than the left ventricle, which is decompressed, and there is an inflow cannula here from the LVAD. So, in thinking about heart failure management, the initial triage is the same. You have to decide whether the patient is hemodynamically stable or not. If there is evidence of cardiogenic shock with an LVAD in place, it is imperative that the patient go to ICU level care, where you are assessing for pump dysfunction. When I mean pump dysfunction, I mean LVAD dysfunction and thrombosis. And we'll get into the details of thrombosis in a second. It is important to quickly obtain an echocardiogram and maybe even a pulmonary artery catheter before management. And also to think about whether the patient is a transplant candidate and how to support the patient until an organ becomes available. In hemodynamically stable patients, it is common for the patient to be admitted to the step-down unit. One has to obtain a good physical exam to try and distinguish their hemodynamic state, and perform some brief LVAD diagnostics to understand whether the pump is functioning appropriately. An echocardiogram and other lab values are important. And then if there is initial response to therapy, then a right heart catheterization may not be indicated. But in patients who have worsening end organ function or refractory heart failure, despite your initial interventions, it is important to obtain invasive hemodynamics. In the next slide, I've tried to develop a system for approaching the heart failure patient who has an LVAD in place. I think it's important, very different to heart failure without mechanical support, that one thinks about right-sided and left-sided filling pressures separately. So in this schema, what we've done is develop 3 different profiles for patients who are presenting with signs or symptoms of heart failure. In profile 1, which is bilateral heart failure, you have evidence of both elevated right and left-sided filling pressures. One may have an elevated JVP, there may be ascites or peripheral edema, and echo may demonstrate a dilated IVC, or if you have invasive hemodynamics, there may be an elevated right atrial pressure. Simultaneously, there may be there's also evidence of left-sided filling pressures that are elevated. This may be in the form of dyspnea, some orthopnea, an increased pulsatility index in the LVAD, or an increased LV dimension in the by echo. When you're faced with this situation, the simplest and easiest way to begin therapy is to first evaluate for VAD dysfunction, and especially looking for thrombosis. But the initial therapeutic intervention is diuresis, and vasodilators may help to help decompress the left ventricle by reducing the afterload faced by the left ventricular assist device. If there is evidence of low cardiac output or severe aortic insufficiency, there may be a role for inotropic support. And these patients may respond by increasing the LVAD speed to further decompress the left side of the heart and subsequently reduce filling pressures on the right through the pulmonary circulation. This is a little bit different from profile 2, where there are limited signs of elevated right-sided pressures. So the patient may not have any JVP. The IVC may be small by echocardiogram, and if you measure it, the right atrial pressure may be low. But they may present with signs and symptoms of left-sided heart failure. Again, orthopnea, PND. And the VAD may give you clues to elevated left ventricular filling, whether it be in the form of an increased pulsatility index, or PI, or a wide pulse waveform. And these are things that can be worked through as you're at the bedside with your advanced heart failure team, your advanced heart failure fellow, and the attending. By echocardiogram, you may see a large left ventricle. Now remember, in a patient with well-supported left-sided hemodynamics by LVAD, the left ventricle should be small. So if you see a big left ventricle, you know that you're under decompressing the left ventricle. In this situation, it's important to know that diuresing the patient may not actually be the best strategy. One may actually increase, as a first strategy, may actually increase the LVAD speed to decompress the left ventricle more directly, while still allowing the right ventricle to have its existing preload. Vasodilators may be helpful, again, to reduce the afterload of the faced by the left ventricular assist device and improve forward flow. In the third profile, which is more isolated right heart failure, which is something that we're seeing more and more of as we both early after implant and also late as the heart failure syndrome progresses. One sees a lot of right-sided symptoms of heart failure, but really limited left-sided symptoms. This is actually a very difficult thing to diagnose because the presumption is that volume overload is biventricular or bilateral. One might see a low PI or a narrow pulse waveform depending on the pump platform, a very small or decreased LV dimension, and if you measure the hemodynamics, a low wedge pressure that is discordant with elevated right-sided pressures. Although diuresis may be a good strategy here, one might find that as you diurese the patient, you actually get more left ventricular collapse, and the pump actually starts functioning. It actually becomes more dysfunctional, or you induce ventricular arrhythmias as the left ventricle collapses around the LVAD. This situation really calls for the initiation of inotropic support, and the idea here is to provide inotropic support to increase contractility of the right ventricle without causing too much vasodilation, which will further decompress the left ventricle. So dopamine is a good agent to begin here to try and support the right ventricle without vasodilating the systemic circulation. Pulmonary vasodilators to improve pulmonary circulation and get more blood from the right ventricle to the left ventricle. And in transplant candidates, you may go as far as considering a right-sided support device until a organ becomes available. In non-transplant candidates, with those with refractory right heart failure, I think it is appropriate at that time to start thinking about consultation with palliative care for refractory right heart failure. So in the last slide, I talked a little bit about assessing for thrombosis and a dysfunctional pump. Fat thrombosis is a fortunately uncommon event, but when it does occur, it can result in catastrophic complications, including cardiogenic shock and stroke. This is an example of a thrombus that is formed on the inflow portion of the HeartMate 2 impella. You can see that it forms in right on that first bearing, and this, when it becomes large enough, can cause pump dysfunction. But before it causes pump dysfunction, one can have manifestations of heart failure, and we actually see evidence of hemolysis as blood coming through the inflow bearing here undergoes greater shear stress because of the clot burden, and you start seeing evidence of hemoglobinuria. You might also see an elevation in markers of hemolysis such as LDH and plasma-free hemoglobin. We were one of the centers to first report that there could be thrombosis late after implant. We showed that there was an increase in thrombosis beginning in 2010. And in the first part of 2011, which was shown in these curves here, we investigated that thoroughly and have made modifications both in our management of the pump and implant strategies that have subsequently led to a reduction in thrombosis rates. Importantly, the takeaway message is that while thrombosis and can be fairly benign in the sense that it may be related to an elevation in LDH levels and otherwise asymptomatic, there is an associated mortality signal with the development of thrombosis, even if it's manifest as just hemolysis. There are many reasons for the development of hemolysis. One of them was the understanding that the continuous flow pumps made patients prone to gastrointestinal bleeding, and that led to relaxed anticoagulation targets and reduced emphasis on post-operative heparin bridging. Patients were being run at lower speeds to allow aortic valve opening to prevent aortic valve pathology, and we have had a higher sensitivity for looking for and diagnosing thrombosis. Importantly, one of those things is the presence of an asymptomatic elevation in LDH. In the past, when we've seen asymptomatic elevations in LDH, we have presumed that it's from hemolysis, but not thought that to be a marker for development of worsening pump dysfunction. We now know that even an asymptomatic elevation in LDH can be a signal that there is evidence that there could be thrombus within the pump mechanism, and when it progresses, it leads to a clinical syndrome of heart failure or even shock. So management of pump thrombosis is multidisciplinary and requires some careful thought, but also a sense of urgency. If you identify a patient with an elevated serum LDH or a plasma-free hemoglobin with or without hemoglobinuria, abnormal device readings, or heart failure, I think it's important to first assess whether the patient has heart failure symptoms and any other evidence of pump dysfunction. We were at one point trying to treat almost every patient that we had with pump thrombosis with intensified anticoagulation, but have subsequently found that in patients who have evidence of worsening heart failure or shock, the best strategy is often immediate device removal or urgent transplantation if an organ becomes available. In patients who are largely asymptomatic, now going to the top part of this algorithm, with normal LVAD pump performance and who are not immediately surgical candidates, we try to increase anticoagulation for the first 24 to 72 hours. This is usually in the form of heparin or a direct thrombin inhibitor, heparin or a 2B3A inhibitor, or systemic thrombolytic therapy in select cases. If the hemolysis resolves, we consider a high iron-R target and/or dual antiplatelet therapy. If there's persistent hemolysis or evidence of thrombosis, patient undergoes device removal. And we have really developed a nice system for a minimally invasive removal of the device, which takes into account the three components of most pumps. So most pumps that we implant have three components. There is the pump itself, which sits in the middle, the inflow cannula, which sits in the left ventricle, and the outflow cannula, which connects the system to the aorta. If you can successfully rule out any evidence of thrombus within this longer outflow graft, it is possible to then exchange the pump mechanism itself via subcostal incision rather than a midline sternotomy. And our surgeons are able to do this very quickly. They perform an incision, they disarticulate the pump from the outflow graft and the inflow graft. They're able to visualize part of the inflow graft and to assess for any thrombus, and then replace the pump mechanism. These patients do well. They have a very short length of stay. They're extubated the day of the surgery and come out to step down the day after. Neurological emergency. I mentioned that one of the complications of pump thrombosis can be stroke, but we've also seen evidence of intracranial hemorrhage due to anticoagulation in certain patients. I think it's very important that if you have a concern for a stroke or a neurological event, there's an immediate stroke code called. We prefer that all anticoagulation is held until the imaging is performed to rule out intracranial hemorrhage. If there is hemorrhagic stroke, that requires an immediate neurosurgical consultation. Reversal of anticoagulation with 4-factor PCCs is possible in this situation after consultation to try and attain an INR less than 1.3. Most of these patients have to be admitted to an ICU, and in the Duke Health System, this would be at 7 West. And then a neurosurgery and neurology should be consulted to help us manage care. We also recommend, based on the previous discussion, that a daily LDH is also assessed, such that we are now looking for thrombosis after reversal. If there is a ischemic stroke, CT angiogram is an important diagnostic tool and prefer to be done when the patient is being assessed with the initial CT imaging. These patients can be candidates for lytics or an interventional radiology procedure, and it's important to consider them for those therapies in short order after symptom onset. In patients who undergo therapy or are not candidates for therapy, it is important to reinstitute anticoagulation and antiplatelet therapy, as well as assessment of the pump to ensure that there's no thrombus burden. Finally, I think it's important to mention briefly the management of infectious complications. In this very cartoon-like schematic of LVADs, I think one appreciates that while the left ventricular assist device itself is implanted in the body next to the left ventricle and provides support. The power source remains external to the body and is connected via driveline. The incidence of driveline complications is not small, and fortunately many can be managed with outpatient antibiotic therapy and local debridement. However, more severe cases can lead to ascending infections up the driveline towards the LVAD pump pocket, and then even systemic infections with bacteremia. If a patient with an LVAD requires admission for infection, we tend to divide up the patient group into those that have bacteremia or sepsis versus those that have isolated driveline infections. If there's any concern for bacteremia, if there's any evidence of bacteremia, one should begin empiric antibiotics, assess for the source of bacteremia with imaging, and strongly consider a transesophageal echocardiogram. Most of our patients who have LVADs have other cardiac, indwelling cardiac devices like ICDs, and assessment of the valves and leads is important with TE imaging. It's important to begin antibiotics early. The typical organisms that we see are skin flora, staph and strep species, but we have seen a fairly high incidence of enterococcus, and the mechanism for that infection is unclear, but may be related to AVM formation within the gastrointestinal tract. So consideration of empiric antibiotics should take into account what we typically see in our LVAD patients. I think it's important to look for evidence of ascending infection, and a surgical consult if there's evidence of soft tissue cellulitis over the abdomen where the driveline sits is a key component of that to make sure debridement is not required. For driveline infections that seem to be more localized, imaging I think is important, particularly CT of the chest and abdomen to look for abscess. One important point is that the radiologist often calls stranding, which may not be equated with abscess formation. We have found that even in the presence of stranding in the soft tissue, there could be areas there that have formed an abscess. So it's worthwhile getting a surgical consultation and a review with our transplant surgeons to make sure that no debridement is required. I think I'd like to stop there, and that was a brief rundown of common things that you may see as you're rounding on the advanced heart failure service with inpatient admissions. We're always available to answer questions, and you'll have the support of the advanced heart failure attendings and fellows as you're on the service. So look forward to seeing you on the service.